Dear participants, I'm honored to open Lithuanian Junior Doctor's first webinar. Today, like never before, we have to adapt to quick changing circumstances to learn new competencies. This seminar is one of the examples. We organized it without seeing each other, without having any experience like this before. Apart from that, just yesterday, Dr. Gregor Prosen was put into quarantine because of contacting with COVID-19 positive patient. So we are very thankful to Dr. Gregor Prosen for presenting this lecture and additionally thankful for not canceling and doing this from his home. Also, we are thankful to Maribor Medical Corporation for the organizational help. As you got the information before, the plan of the webinar is presentation and after that questions and answers session. That's it for the opening words. Let's hear Dr. Gregor Prosen himself.
Hello, good day from Slovenia. Thank you, Tadas, for your kind invitation. Thanks again to Maribor Corporation for setting us up technically so fast. Tadas, as you said, this is unprecedented. We've never met. I hope we meet in person soon. We've never met even with the company in vivo. But let's see if this wonder of technology works for something good. I'm emergency physician working in Maribor, Slovenia. I work mostly in emergency department, but partially also in pre-hospital unit. I also teach at a local university, and I am member of WinFocus, World Society for Critical Ultrasound, and also for USAM, that is European Society for Emergency. Below is my Twitter handle where you can contact me anytime, and I hope I will be clear and loud enough so that you don't waste your hour. As first and foremost, most important, I don't have any conflict of interest. As Tadas said, we've never met. There was no money exchanged, and let it be that way. It is for the common good. On the other side, I am not maybe yet expert in COVID-19 lung ultrasound. Also, this is evolving field, so please monitor, stay up to date with the resources that are coming out daily. And I will not give specific instructions on managing the patients because that is a little bit local specific, not to mention that not all questions about role of lung ultrasound in the management are clear. As I'm a member of WinFocus, few slides I have stolen, quote unquote, from WinFocus slides, so courtesy is due. But other than that, there is no conflict of interest. I just want to present what little experience I have on this COVID connection with lung ultrasound and what is generally an introduction to ultrasound of lungs, which we do here in Maribor now for past 10, 11 years, truly on daily basis. So my aim is to present you what this is, this technique of lung ultrasound. I guess you are mostly novice learners to this field. I would like you to understand how it is done, how it's used, and also its limitations, and maybe very utilitarianly help you to develop a certain protocolized skill that maybe in future need, hopefully not, but some of you maybe, you will need, you can use, and perhaps if this telemedicine experiment works, then certainly there is a role for a lot of people being able to perform lung ultrasound and then someone guiding you or helping you with interpretation remotely. Again, this is a crash course format, so please don't mind if I slip in any parts, but I'll try to make it as interesting and lively as possible. What is ultrasound? Ultrasound is mechanical vibration and energy of matter. It is not electromagnetic radiation. This is where the matter, the atoms actually vibrate.
Sound is the sound that is higher,
and ultrasound is the sound that is higher from what is hearing sound. This is what, on the lower frequencies, of course, this is what bats use, dolphins, and also some other
dark
creatures, so they can see, field of vision to see. I would like to put it very clearly and simply. Ultrasound used in medicine is in Latinic languages is very appropriately called echographia, because this is what it is. It is trying to draw a picture of something, of the content of the body, let's say, with the aid of echoes. So as we have electrocardiography, EKG, or capnographia and tidal CO2, we also have echographia. And this whole concept of machine works on a very basic physics that I will try to make it interesting and vivid for you. So not only bats and dolphins use it, but also sonar is one type of ultrasound used for same purpose as dolphins use it, and that is the sonar or dolphin sends the ultrasound waves into the depth of the sea. And in the sonar, of course, if everything is blank, if there is no ultrasound, then the screen remains blank, or in our screens it is black. And then the machine, the sonar, sends the pulse out. And what sonar or ultrasound machine does, it is listening, not only transmitting, but also listening. It is receiving if any ultrasound echoes are coming back. And it computes, it calculates if certain echo is coming back after more time, then it presumes it is in the deeper part of it. So here on the picture, let's say there is time 2, and that means no echo can come back in the depth of 2, and then one more impulse that is returning after, let's say, time 3, and this is where the sonar knows, somewhere in the depth there is an echo, and then it will draw the silhouette. Maybe because I have the wonder of technology with me now, maybe I will try to demonstrate very practically. Ultrasound probe is water resistant, and this is my simulation of the lake or the sea or water canister. And then I will put the screen on of ultrasound, and as you see, it is black because there is no ultrasound being transmitted through air. But then I put it into the water, and suddenly you see there is much more happening inside, even some specks. But definitely the screen becomes black because water is completely transparent to ultrasound. We say it is unechogenic. Now I'd like to show you if I put in a metal, you see it's a lid from the teapot, I will put it in. Let's see how that looks under ultrasound. And I think it's fairly obvious to see that we can make exact shape of this lid, even with the bell, because metal, of course, does not transmit ultrasound, and the echoes will go back to the probe completely. So bear in mind, only this white, it is called hyperechogenic line because it is very much producing echoes. This white is actually the surface of the metal, and below it, whatever you see below are actually artifacts. The ultrasound cannot go through the metal lid. but you can make the shape, right? Like a silhouette, like before I showed with fish, or that's how the dolphins can see the whole flock of fish. Now I will take this thing out, which is metallic, and I will put in my old sponge, which you see it's so old that it is so absorbed with water it will not even float. But we'll use it here for experiment to show you how the sponge filled with water looks like. So this is water, and I think it's fairly clear to see that this sponge is full of water, and it gives certain gray appearance, a little bit like liver or spleen and so forth. I will try to make it even more. You see, I squeeze out the air. The air bubbles are white, and now it will absorb even more water. I think it's obvious to see that the Villeda sponge is gray on ultrasound because it is full of water. And this is the principle of ultrasound, right? So we can see definitely there's an object here. Okay, so this ultrasound use was known from 50s, 60s, but there was very recent use in lung ultrasound. Because researchers, clinicians didn't comprehend the true mystery and mystique behind it. And that is, lung ultrasound is a little bit like hieroglyphs. If you don't know the code, they're meaningless, right? Like, I have no idea what this is written. But if you can read the patterns, then there are definitely specific patterns for specific disease. So lung ultrasound is different than lung ultrasound of other parts, which can be quite intuitive, especially if you have good anatomical knowledge. Lung ultrasound is different because it is based on pattern recognition. And now I would like to go through which are these basic patterns. And we have to go back to ultrasound and lung ultrasound physics. And I don't want to be too nerdy, but basically this whole lecture, it boils down to this graph. And this is the graph that shows the ratio of air and water in different pathologies. And so then we can just think about how different pathologies, pneumonia, pleural effusion, interstitial syndrome, pulmonary edema, COVID, pneumothorax, what is the ratio of air and water in that pathological organ or in that area? And let's say if the ratio is infinite, because there is water, so air is 1, but water is 0. If there is only air, so the water is 0, denominator is 0, then the formula, of course, the result is infinite. This is very much similar to what I will show you now on the screen. Imagine I'm exploring this area here above the probe. This of course is air, right? And if I put the gel on the probe, you will see a very distinct pattern. And the pattern is something that is very similar to the pattern that you will see in the lungs. I will put the pointer on, and I will show you that actually what we're seeing in this picture is mostly artifacts, and these are so-called reverberation artifacts, these horizontal lines. So actually, this is the probe up here. And only this piece here, this layer, is gel. As you see, it's watery, of course. It has some electrolytes for conductivity, but otherwise it's completely anechogenic. And this white line is the interface between gel and the air. But now, bear with me. This is now the magic and the, how would you say, the conceptual shift. Anything that you see below this line, all this is actually artifacts. These lines are not there. These lines are reverberation artifacts. If you bear with me, look, this line has arisen exactly as the length between the probe and the air gel interface. So this length goes here, and another length goes here, and another length goes here. And these horizontal lines are actually reverberation artifacts, and these same lines in the lung are called A lines. And they are generated because ultrasound comes out with certain energy. And then this, I would say it very simply, this ultrasound would like to go and travel through the gel and out, but it is blocked by air. And that's why it goes straight back. But the transducer doesn't know that this is suddenly, there is suddenly no transmission and blockage. The transducer only knows that something came back. That's why it thinks, there's an echo. So it draws a very white line. But since there is quite high energy, then this beam of ultrasound bounces back, forth, and the machine is fooled, thinking then, after time 2, another line. After time 3, another line. But the main point here is that below this line, all these are actually artifacts, but very useful artifacts, because they show that whatever we are looking now is basically not permitting the ultrasound. And as we know, this is over, let's say, thorax. Then we know, this must be air. So that must be aerated lung. Now, let's move with our experiment. So this is the blueprint of air on ultrasound. Now, let's go back how we see our sponge that is completely submerged with water. So we were here, right? It was only air, infinitely air. The ratio is infinity. And this is how it looks, right? But then on the other side, if there is no air, only water, the ratio, of course, is 0. Then this is what normal pleural effusion or any other effusion in the body would look like. It is black because fluid is black. And if we go back to the ultrasound, this is what we are seeing now. I put the probe from the air. As you see the air interface in the water. And what I see now suddenly is black fluid, and below is my Villeda sponge. And this Villeda sponge echographically much, but it seems that this sponge really absorbed the water, which is quite easy to understand because it is submerged, it's not floating. So this gray. This is actually how most organs, liver, spleen look like, because they're basically a lot of water encapsulated in certain organ. But physically, they are mostly water, like this sponge.
But now, bear with me, and I hope this works. I will take this sponge out. I will take the water out, put it here. This is our sponge. It's completely dry. It's completely dry. I put the probe on. How does that look now? I think you agree with me that it looks much more like air, right? So this is the gel. This is the surface of the sponge. This is gel sponge interface. And because this sponge now is again full of air, it doesn't permit ultrasound to go in. So we are back to the ratio 1. But now I'll show you magic, and I hope it works. I will try to make this sponge only little bit wet, like this. Ha! Great. Now I hope you see something changed. And what changed is that when we added water, these vertical artifacts appeared. So this sponge is now outside in the air. It is not full of water like it was inside, definitely not, but there is some water. But there is also some air. And what we can see on the surface is these B-lines in the vertical artifacts called B-lines in the body. And these B-lines show us that this lung, this sponge, is still some air, but also getting some water, starting with alveolar edema. And if we press some more, if we press, you see now I'm pressing, now I can start to see that this is sponge. So I can see through because it's filled with water, but inside there are still white dots. And these white dots are actually trapped air inside the sponge. And this is quite similar to what I will show you on the slide, which is lobar pneumonia. We were here with completely water, and then we are now here, where I show you the vileda, the sponge, or the lung is mostly flooded with water or inflammation. Basically, that looks water. But inside, you can see like some white specks, white dots. And these are trapped air. And this is how lobar pneumonia, let's say, looks like. And around there is some fluidothorax. And in between, as I said, where there is more air, but still water, so let's say alveolar edema of lung, where I put the sponge out, this is where the vertical artifacts appear. And these lines here in the left side are called A lines, and normal lung looks like this with A line. And these vertical lines are called B lines. I don't know why, by Dr. Lichtenstein, and he was researching that in Paris 35 years ago. I guess he was the first, and he said normal is A, pathological is B, so B. So we have A lines and B lines. So this is the physics behind. I hope it's fairly clear. You see the pattern on the ultrasound screen now? So that was consolidation with some air inside the lobar pneumonia, let's say pneumococcus pneumonia. But let's see what is my pattern now. I think I'm eupneic. I think I should have good saturation. I don't have any respiratory symptoms. So I guess my lungs should look like they are well aerated. meaning they should have only horizontal A lines. Let's see the moment of truth. Ta-da-da. Yes, I think so far so good. So my probe, I put my probe exactly perpendicular to the rib. So I'm going through the rib and through the intercostal space like this. I put it on, and you can see my rib, my other rib, and just below, so this is one rib, other rib, and just below is white, hyperechogenic, so very white line called pleura, of course. This is pleural line. And if you can see, I'll put it here, when I breathe, it actually moves. And I hope it is visible to see that I have certain A line. So that means that my lungs should be quite dry and quite well aerated. So I shouldn't be in interstitial edema. And one more thing, pay attention to the pleural line here. You cannot make a distinction between visceral and parietal pleura, but you can see that it is moving. Look at the marker now. Something is moving there. And this is the proof that I am ventilating, that I am moving my lungs. And my lungs are expanding, and my lungs are adherent. And this is very nice trick. If you look up here on apical, or if the patient is supine, you look up there. And if you see this clear lung sliding, movement of pleura horizontal plane, then there is no pneumothorax. There cannot be pneumothorax because obviously for this movement, for this sign, we call it lung sliding sign. For this sign, there has to be visceral pleura adherent to parietal pleura, and they're moving like this. So from my scan, I can say that at least in one part here, my lungs are well aerated. They have the Aprofile, and the lung sliding shows me that I don't have pneumothorax, because in this sitting position, the air should go up. And strategically, I checked here, and there is there is lung sliding here, so there should not be any pneumothorax. And that is super nice in shock states, in trauma. You check few seconds in each hemithorax, and certainly you shouldn't miss major pneumothorax. But as I will say with all the other applications, the more spaces you scan, the better. As the more you auscultate, the better. So I just wanted to show here, from my perspective, excellent article, which proved what I was trying to prove now with the sponge, that sometimes they have to do this whole lung lavage for certain rare disease, I think proteinosis of lung something. And in order to get these proteins out, they would lavage the whole lung, intubate into one side, lavage, and then intubate other side and lavage other side. So if you imagine, the people come with the disease, and then they are pretty much they wash out their lungs. And here are sonographic patterns of the steps. And as you see, people come with certain degree of inflammation of these proteins, with their interstitium of lung interstitium being thickened. And they have these B lines, as you see here, some vertical artifacts. And then in second step, they get the water in. And this is where the interstitial edema properly starts. And then the whole lung is submerged, but still there's some air inside, like air bronchogram, like in pneumonia. And in fourth stage, complete submersion, like with complete atelectasis, no air inside. And again, it becomes very gray. And then going in reverse, they suck the water out, and the water goes out, more air comes in comes some B lines, vertical artifacts, and in the end, the lungs are well aerated. The lung alveoli can fill in completely, and there arises beautiful A lines showing that these lungs can expand and be aerated. So I think it is very, very nice clinical experiment to prove this physical concept. So, not to belabor you, what that means in clinical practice, how to perform lung ultrasound. What you will always put the probe, as I did, you will put the probe perpendicular to the intercostal space. And you will start with anterior on both sides, let's say a little bit above the heart on left side and same on the right side. And because you are perpendicular, you will identify the rib, and you will identify the rib acoustic shadow behind. And the first line behind the rib is the pleural line. And this line is quite important, and I would like you to think about it as a certain anchor, like a landmark, or like in EKG, like ISO line. Like this is the baseline. And you have to know which one is pleural line, because this is where all the pathology and interpretation starts. And the easiest way to do it, to interpret where is the pleural line, is to identify ribs first, and knowing that pleural line is the echogenic line just below the ribs. And then at the same distance from probe to the pleura, inside there should arise first A line, second A line, and so forth. So that's why you will take, for lung ultrasound, you will mostly take phased array probe with depth around 15 centimeters, so that you will see what pattern arises in the depth. So this video here would be called Aprofile, because it has A lines, and also it has pleural sliding, which, as I said, excludes pneumothorax. But it excludes pneumothorax in this locality, in this geographical location, not somewhere else. So most importantly, as I said, take your ribs as a landmark, take it as an ISO line in the EKG, and this is where you find your pleural line. And this pleural line should be white. This is hyperechogenic, and it should move horizontally, and this is called pleural sliding. This is normal, of course, but it also excludes pneumothorax. Opposite is not true, but that is another webinar, to be honest. Now, very, very, very simply put, A lines means aerated lungs, at least in that locality. That's why we will look in 12 spaces, 6 one side, 6 the other side, and then you interpret it as mostly A profile, or you say diffuse B profile. And one more caution, all this, it holds true if pathology reaches pleura. So that means that some bronchial pneumonia, or even more importantly, bronchoconstriction, COPB, asthma, does not have any different lung ultrasound pattern than normal. So beware, you can die from severe asthma or COPD or pulmonary edema because pathology is not showing in pleura. All this, what I'm saying here, is only true if pathology reaches pleura, which in the case of COVID, it actually mostly does. So that's why it's still useful. So be careful. Our lung ultrasound can only look at the surface of lung, that is on the pleura. And if pathology is deep inside and it has no connection with pleura, you will not be able to see. That's why chest X-ray, CT, of course, are not dead yet. Even if lung ultrasound is totally non-invasive, safe, and very easy to do. So, few things that I would like you to remember when you meet up again, speaking or with clinical scenario. So, ribs as a landmark that will show you pleural line. And this pleural line, there should be pleural sliding or lung sliding. And A lines are those horizontal lines, but beware, this is not lung tissue, these are artifacts. And same, B lines are not lung tissue, they're artifacts, but they are vertical, going down, like you will see in the video. And the B lines, by definition, they arise from the pleura. And they move with pleura, of course, because they move with respiration. But I will show you also video. You will also be able to see consolidations. Like it will look very similar to the sponge I show you. And this is consolidated lung. It cannot exactly show you why, or this is quite advanced. But that's why, don't forget, you are doctors first, you are clinicians first, you take history first, and then you use ultrasound on top of it to differentiate some more. And of course, you will be able to see pleural effusion. This is nothing new. Internists have been using it for 50 years. So that is above the diaphragm, it's full of black. Black is fluid, and mostly inside the effusion, there you will be able to see some part of lung. Okay, so next pattern, what I wanted to show are these B lines. As I said, on the pleural line, you can see vertical artifacts. I think it's quite obvious that this is not the same pattern than one before or the one that I have. These B lines, if there are 3 or more in one intercostal space. So that's why it's quite useful that you stick to intercostal space. It is, if there are 3 or more, it is called interstitial syndrome. It is called interstitial syndrome. I want to go out of here. So interstitial syndrome, and this is radiographic diagnosis. But then based on clinical suspicion, you then can make good judgment if this is cardiogenic pulmonary edema. Quite similar is RDS, and quite similar to this, what you're seeing now, is also COVID pneumonitis, because this is one form of RDS. So pulmonary edema, but not due to cardiogenic hypertension, but due to inflammation. And here, as you see, all this pneumonitis, the inflammation is flooding the alveoli, and that's why it's making sort of alveolar pattern. And different pattern, the third pattern is something that you can see is like a consolidation, is consolidated lung. I think it's quite logical. And inside you can see white dots, white specks, similar to what you saw on my sponge. And this is consolidation with air bronchogram. And again, in correct clinical picture, this is how lobar pneumonia looks like. Because you must concur that this part here, when they're not breathing, this part here looks very similar to liver here, right? So that means this lung has a lot of water inside. And when you see this, I think it's then very clear why in pathology class we were taught that pneumonia goes through 4 stages, and stage number 2 and 3 are hepatization, hepatizatio rubra and hepatizatio grisea, and then resolution 4th stage. So that is consolidation. In COVID, consolidations are not as big as this, mostly. There are more subtle, and there are consolidation just below the pleural line. So B lines on the pleural line, the pleura looks to be more thick, and inside you can have such consolidation and also white dots. And this is ordinary fluidothorax, pleural effusion, as you see, black, and some remnant of atelectatic lung, and this is diaphragm, and this is liver. So I think this is fairly easy to recognize. Beware, in COVID, the pleural effusions, or at least de novo pleural effusions, are very unlikely. Pleural effusions are something more chronic, even malignant, or many patients in heart failure, chronic heart failure, also have at least minimal pleural effusion. In COVID, the reports are pleural effusions are quite unusual. Okay, so going through lung ultrasound, I hope it was clear demonstration of there is normal pattern with A lines and pleural sliding, and with pneumothorax the pleural sliding is missing. But then if there is more water, like interstitial syndrome or interstitial pulmonary edema, there appear B lines, and if there is water even more, there can be consolidation. And of course, around consolidation, this is also consolidation, around there is pleural effusion. Okay, so before we conclude and I take some questions, I would very much like to emphasize this is new developing field. Articles on COVID and also on LUS, on lung ultrasound, coming out pretty much almost every other day. So please, let's monitor. Now the Italian colleagues are working hard on a study and to publish it on an even bigger scale. But the Chinese have so far published this study, little bit small numbers, around a few dozen. But what they show is, again, quite consistent and logical. And they show that the pleura, unlike my pleura that was very thin and regular, and it was only moving left and right, this pleura becomes more thickened and irregular. Like if someone, like a mouse, was nibbling on the pleura, then appear B lines, which of course are a sign of interstitial water. And there can be focal or multifocal, confluent, meaning that you cannot even make difference from one B line to the other. In ARDS and also in COVID, mostly B lines follow the glass, ground glass pattern of skipped lesions, meaning there is a little bit of B patterns and a little bit clear. Again, B patterns, clear. B patterns, clear. And this is corresponding also with ground glass of CT. Then, with more severity, there appear to be some consolidation. So this pleura gets some gray below it. And then, in the recovery, of course, the lung have to reconstitute, and they're going back towards A lines. And as I said, the pleural effusions are quite uncommon. So if you see pleural effusion, either they had it before, or it is luckily not COVID. Another group of Chinese, now they shown the lung ultrasound patterns with CT, and as you see, this patient had fairly beginner or fairly small starting lesion, And as you see, some B lines or vertical artifacts on lung ultrasound at this place. So if you looked with ultrasound elsewhere, like here, you would get probably normal A pattern. And one other thing that Chinese report is that this pathological pattern, have predilection for posterior and inferior parts. So that means you also have to look in the back. And I think similar or even same case, but with some progression. And as you see, there are no more A lines, definitely not. But these B lines seem to be confluent, meaning they're not even separate B line anymore. It's like a whole curtain. And this pattern would be moving left, right, and it would be like a curtain. You cannot even count B lines. But there's definitely this pattern. And then worsening symptoms and also CT pattern, you can see even more ARDS. Below, this is what I was talking about, subpleural consolidation. So that is pleura, and these are subpleural consolidations with some air inside, and below also some vertical artifacts, which technically are not B lines, but it doesn't matter. So this appears to be the evolution of disease in individual pattern, and this appeared to be patterns in ill patients with COVID. Now, $1 million question for now, hopefully with better studies coming out, is what to make with it. And here opinions are based on few studies with fairly small numbers, but then there are experts on various groups on WhatsApp, on Twitter, and so forth. The social media have gone aflame, and what they are pretty adamant and consistent is that you cannot predict very linearly, but definitely you cannot predict who gets better, who gets worse. It's not so easy as we would like it to think, but it seems like clinical people with appropriate clinical picture with pneumonitis ongoing definitely will produce the B lines, that with worsening will go into thickening and consolidation. And probably those people on the later pattern that I showed you with Chinese are more high risk than beginning of B lines only that I showed you before. So this is one thing. And the other thing, that probably decisions who get admitted, who doesn't, is also probably will be based on local resources, local politics, and it will even change in same locality. So about that, I don't want to make much verdict beside basic physics and cases that I've shown you, but please stay tuned for more information. What are those patterns that are predictive of this patient can maybe go home, this patient can benefit from non-invasive ventilation, or this patient probably will need to get intubated. My dear friend Elmo Pereira is intensivist in Rio de Janeiro, Brazil. And incidentally or not, he also got in contact with the COVID patients, taking care. And thanks to him, courtesy of him, and of course, patient consent, I would just like to show you what he observed and what was the correlation with CT. And as you see, this was the patient with fairly okay looking CT, not much. And then from my understanding, 3 days later, he felt pretty much the same or even better, and they wanted to discharge him. But of course, since ultrasound is so easily available, Elmo put the probe on, and this is what I want to highlight now. as I said, a third intercostal space. So that is one region. And here, I think we can see predominant A pattern with very few one or two vertical artifacts. Okay, one B line here. So that was anterior. Anterior, inferior, pretty much similar pattern. As you see, A line, a vertical artifact. And then we go posteriorly, more black. Now I think it's fairly clear that the A lines get erased, and when they breathe in and the more posterior part comes in, there is obviously much more B lines. Similarly here, this is phrenicocostal, this is liver, this is phrenicocostal. The edge of the liver comes in, look at that. This liver has thickened, irregular, and some B lines. So that doesn't look best. Similarly, anteriorly, Aprofile, anteroinferior, close to the heart, a little bit suspicious for B profile, but look at that. So this is more posterior, and you can see confluent B lines. And I would dare to say this is one small subpleural effusion. And some more, look, definitely B lines and definitely consolidation. Look at here. Look. So this is pleura, and below the pleura there is gray and some white inside, so that's trapped air. And this lung getting severely ill. Now they control CT and look at this CT now, 3 days later. Obviously worse. And there's posterior predilection for the disease. Look at this. This is where we watched the clip. The patient they had, look, this patient has B profile, B lines, even anteriorly, and this, I would dare to say, is quite thick. And lower down, confluent B lines. There's not even single B lines anymore. It's a curtain of B lines and some subpleural consolidations. That does look good. Little bit better on the posterior side, better. And I think consolidation inferior. Left side, not too good. B lines. Some worsening and some thickening of pleura. Similarly, B lines here. Similarly, here. Then ending 4 days. Look at the labs. Very significant, especially. But regarding lung ultrasound, there was still some consolidation in anterior parts, maybe a little bit of resolution anteriorly, maybe resolution, less B lines in posterior parts, even appearance of Aprofile, and similarly on the appearance of A line looks perhaps a little bit better. And as you see, less B lines and appearance of A, but still some remnant in posterior parts. So of course, as we know now, this heal quite slowly. Some of them demand weeks in the ICU, so also changes don't appear to be dynamic and changing. Our Yale on Twitter, he posts every day his COVID lung ultrasound exam. He puts on his clinical status, his oximetry, and his lungs are also going around B lines, some consolidation, and now improving, luckily, back to B lines. So our Brazilian colleagues also did a infographic with this need for systematic view of lungs. So you have to view lungs in at least 12 positions, 6 positions. For monitoring, it's best, of course, to position on the same position, and they've put in the standard pattern of A lines and the rib, pleural line, and so forth. So just to remind you, try to be systematic, and if you find yourself in need, in case that maybe you present to other colleagues or the lung ultrasound and someone is on the teleconference with you, then you know where to put the probe, put it perpendicular, try to interpret the pattern. And what they recommend, of course, is that the lung ultrasound could be used in the COVID patient. Once again, the evidence behind this COVID community, please be safe and put your section first. Without you, without our safety, our health of our patients, then it's useless. You will, in COVID patients, or mostly in lung ultrasound, you will choose phased array probe, that is so called. Put it in 6 pretty much places, anterolateral and posterior, upper, superior, and inferior. Place it perpendicular. Try to identify those ribs and shadows of the ribs. And then just below the ribs, there is hyperechogenic pleural line that, of course, should be moving, pneumothorax, let's say, or the patient is intubated in the other side, and so forth. And in case of your B lines that can be of very different patterns, but B lines are vertical pleura, the pleural type, you can see some white specks, and from those specks and from consolidation below, there can also be cervical artifacts. Usually, there should be a much pleural than no pleural diffusion. Okay, there is much more to talk about lung ultrasound in medical medicine, but I hope that's enough for now. And thank you for your time, and I'm ready to take any questions that you might have.
Thank you for the lecture of yours, Dr. Gregor Prosen. Let's start the questions and answers session. So the first question is, if lung ultrasound with peripheral capillary oxygen saturation can be used for triage?
Yes, my understanding, again, I haven't seen papers so far, but there was 2 days ago in Medscape a short article on Dr. Volpicelli, who is also part of the lung guru. He was interviewed and he said, this is what they do. Exactly what you said, sort of a triage to see where in the development of the pneumonitis. But from my understanding, that it's not with ST elevation. You have to take and clinical context first. These B lines or subpleural are pretty much physically, in physical terms, are manifestation of ARDS. It could be anything, but of course, in the pandemic, we think of COVID first, of course. So it takes into account clinical picture, the patient that I was in close contact, and then now I have to isolate. When I looked at him sonographically, also in his zone, of course with the full equipment, what was striking was not these B lines. I've seen many pulmonary edema patients, and I thought it was pulmonary edema. But then on the back thought, there were some consolidations. But even that, I don't think I would dare to say this is COVID. But what now makes sense is that he was disproportionately too well, not enough dyspneic for severe hypoxemia. And this is what they also report. People come in with 75 nation, and they don't look very ill. And this is the patient that was here. So if you combine clinical picture with saturation, with lung ultrasound, you have a much more powerful tool. But of course, I think is the future, because there's no way we can put everyone into CT. So my answer is yes, definitely there will be role, but stay tuned for how exactly we should use it. Thank you. Next one.
Thank you for the answer. The next one is if artificial intelligence can be used for lung ultrasound.
I'm not sure, because ultrasound, point of care ultrasound, lung ultrasound that we did so far in these dozen years, it hinges on assessing of pre-test probability. I'm not sure that these patterns, sonographic patterns, are specific enough without other information, until we have of all these patients, probably correlating with CT and other patterns. Unless then, I'm not sure if I would say this is so. I've seen few pulmonary edema patients, and I must say that I was very easily fooled. But I dare not claim that I'm super. There is a role, but I don't think there is a role yet. These other things like triage, initial treatment of patients, I think these things have to be used. And AI will come when there's more.
Thank you for the answer. The next question. Is there any difference if cardiac or abdominal transducer is used?
Yeah, again, colleagues report that there is, but I would put it very honestly, very bluntly, if any other probe, then I guess the abdominal probe will do as well. It's important that abdominal or cardiac, in quote unquote, you set them to proper depth, and that is at least 15 centimeters, because you want to see the pattern in the depth. With linear, only few centimeters of penetration, you only see pleura, and you can maybe see first reflection. But for the proper interpretation, and also to see deeper into consolidation or effusion, you want the correct depth. So this, I think, is more crucial between cardiac and abdominal. But preferably, although so far I've used, I hope I'm not incorrect, good enough. Next, please.
The next question is if we should use particular ultrasound device exclusively for suspected COVID-19 patients.
Yes, absolutely. At least in our ED, we have sacrificed one machine just to the COVID department, the gray zone, and it's used only there. Which does not mean that we don't take extra precautions, because in there as well, we don't know who's infected, who's not. So we take extra cleaning precautions between each patient because we can protect ourselves and be quite diligent, but then the probe and the gel can be so easy to transmit. So yes, my answer is preferably use it only in unclean COVID area, definitely. And clean in between. Gentle wipes and so forth.
Thank you for the answer. The next question is if COVID-19 has something different that would help to differentiate from pneumonia.
Yeah, so usual pneumonia, and now I will speak only from my experience, usual lobar pneumonia should be lobar pneumonia mostly in one lobe. You see the consolidation. It's quite deep, few centimeters in depth. Very acute, very fresh pneumonias don't have much pleural effusion. You see air bronchograms. But with COVID, from my understanding, the whole process is much more diffuse. So it's much more diffuse, it's much more ARDS-like, and that means that these consolidations are like a streak. Like you saw in the video, is just 1 centimeter maybe, or something like that, below pleural line. It's not the whole hepatization like you see with nice lobar pneumonia. And then if you go away from lobar pneumonia, there is Aprofile elsewhere. But here, as we saw, mostly posterior inferior, both sides, B-lines, dirty, thickened pleura, and subpleural consolidations. I hope it helps.
Thank you for the answer. And the last question of this questions and answers session is if you have a protocol for the lung ultrasound changes in your hospital.
Good question. And the answer is no, because we just got few so far in Slovenia. And in my city, specifically, quite less up until today. Only few in the ICU and a few going through. Now, bear in mind that not everyone is proficient in loose. So there is no protocol as such. Plus, we workers in the ED are also now physically isolated from the workers in the dedicated COVID ICU. So to be honest, there is no much interface, but with growing faces, with growing numbers, hopefully not too many, I think we will start cooperating in this part, perhaps monitoring what other colleagues are reporting, as you said, to have a protocol. And I will try to get, and definitely will tweet, the protocol that already Argentinian colleagues have, where basically they divided the lungs into areas. And then, as we saw with Elmo's cases, you scan every day in the same place and you see what is happening. And this is why I wanted to emphasize these patterns. These patterns are alphabet of what you would put in. So one day you would say predominant, or rather you would say B lines, pleura still thin. Tomorrow there might be more B lines, pleura more thick with some beginning of subpleural consolidation, like this. And then, of course, times 12. Hope it helps.
That's it for the questions and answers session. Thank you very much, Dr. Gregor Prosen, for the answers and lecture. Also, dear participants, thank you for attending this webinar and see you in the next Lithuanian Junior Doctors Association events.
Yes, thank you for bearing with me. I hope you didn't fall over, and please stay safe. Okay, and let's keep in touch. Gregor Prosen, that's my Twitter handle, and we can keep there. All the best. Goodbye.